Good afternoon, everyone. My name is Temur. I'm one of the Jackson Memorial Hospital internal medicine chiefs, and today I have the honor of introducing today's speaker, Dr. Michael Huber. Dr. Michael Huber is an assistant professor of clinical medicine in the Division of Geriatrics and Palliative Medicine at the University of Miami Miller School of Medicine, and he is also the co-chair of the Ethics Committee at UHealth. Dr. Huber completed internal medicine residency and fellowships in hospice and palliative medicine and clinical ethics at the University of Chicago. Dr. Huber's research interests include the intersection of bioethics, serious illness care, and informatics. His work examines ways to measure and improve the quality of serious illness care and advanced care planning using the electronic health record. He also examines hospital-level variability in serious illness and end-of-life care, with a particular interest in code status orders and end-of-life and life-sustaining medical interventions. Dr. Huber is the current chair of the ethics group for the Academy of Hospice and Palliative Medicine and was named an emerging leader in palliative medicine by this academy. Please welcome Dr. Michael Huber.
I don't know. We had a person here a week ago and they said, okay, don't load the aspirin. And Flavix wasn't active.
Thank you so much. I appreciate the introduction and the chance to talk here today. I have no financial disclosures, but a few other disclosures. This is an ethics talk. I'm going to do my best to talk through the ethics literature, but it's all ultimately going to be my view of these issues. And you may disagree, you may strongly disagree. There'll be time for questions at the end. It won't be enough. I'll stick around. Also, feel free to put questions in the chat. Also, I work here, so you can find me in the halls and argue with me. Also, if you were coming to this talk looking for definitive solutions to what are largely intractable situations, you're going to leave disappointed. I'm going to do my best to chart a path forward, but these are not things that are going to be solved in this hour. So we'll start with a case. Mr. J is a 68-year-old man with metastatic pancreatic cancer. He was diagnosed a year ago. He's been doing poorly for the past month, essentially bedbound with a poor nutritional status. His oncologist has had to hold cancer therapy. He becomes short of breath at home. His son calls 911. He's brought to the hospital where he's intubated in the ER for hypoxia from a pneumonia. He's brought up to the ICU and stabilized and remained stable a few days later, though unable to wean from a ventilator and requiring critical care interventions. So I am choosing this case and therefore picking on my GI oncology colleagues, but for the sake of this talk, Mr. J could really have any advanced illness, heart disease, lung disease, neurologic disease, and be near the end of life with a poor prognosis and getting critical care intervention. So, many of the patients you care for may end up in this situation. And while my interest lies at really the use of life-sustaining interventions with patients with poor prognosis, part of why I'm interested in that is that the ethics around that, I think if we can start to put in frameworks or answer questions, that can be broadly applicable to many situations, even in the primary care clinic or the rheumatology clinic. So hopefully this is broadly of interest to this broad audience. So Mr. J is, like I said, on 3 or 4 days of critical care and stable, but not improving and remaining ventilator dependent. On rounds in the ICU in the morning, a resident says, "Why are we doing this? It's futile." This is not an uncommon concern among ICU clinicians. In this one prospective study at an academic medical center, researchers surveyed clinicians daily prospectively, asking them if they felt that any of their patients were receiving futile care by some definition. And at the end of 3 months, they found that 11% of patients in the ICU had received at least 1 day of what the ICU clinicians worried was futile care. When the resident on rounds is exclaiming, "Why are we doing this? It's futile," she could be asking this or using this word in many different ways. And most basically, it's a cry of moral distress, a worry that what we're doing doesn't seem right. But the word futile and efforts to define it have had a particular meaning in the clinical ethics literature. And really, this term futile has been an effort of clinical ethicists to define interventions or situations in which it may be appropriate to withhold or withdraw a treatment, even over the objections of a decision maker with capacity. So when we say futile in the ethics literature, we mean a very specific thing. We're going to work through that, but before we do that, we need to work through some more basic ethics frameworks. So Perhaps the most common ethics framework is principalism, which centers around these 4 principles first described by Beauchamp and Childress in the 1970s. And this encompasses autonomy, the idea that a patient should decide what happens to them or their body. Beneficence, we should be doing good. Non-maleficence, we should not be doing harm. And justice, which encompasses fairness, equity, equality. From antiquity through most of the history of Western medicine, physicians were the locus of decision-making. And we hope that they were making those decisions centered around beneficence and non-maleficence, trying to do good and not do bad. Starting in the 1950s and tracking societal changes, also tracking responses to atrocities of medical care in World War II, of research atrocities, and many changes in society, there was an elevated recognition and eminence of autonomy in relation to the other principles. This was codified in Supreme Court cases and widely recognized in a major shift in clinical ethics. And this recognizes that patients may choose to do things if they have the capacity to do so, even in violation of the competing ethical principles. They could forego beneficial care, or they could accept even harms if they were making that decision through their own autonomy. And so autonomy took greater weight. Let's make it a little bit more complicated. So we're very familiar with the idea of consent, which is how patients exercise that ethics principle of autonomy. And so the healthcare team, the patient work together, the patient is proposed with choices, the patient agrees to those choices with capacity and understanding, they then consent to that. But the healthcare team can make decisions outside of patient autonomy. And those are decisions that I call unilateral to the healthcare team. It's the paternalism of antiquity. The doctor, the physician, the team is deciding what's happening. And when that happens, one of 2 things can happen. The patient or their representative could accept that decision without opposing it. And we call that situation assent. Or they could actively oppose that decision. And then we're in a situation of conflict. So walking through this, let's think about Mr. J. He does not have capacity. His decision maker is his son. The ICU clinician could have a goals of care conversation and understand that Mr. J would, not want prolongation of life in this setting. And the ICU clinician could then say, I recommend focusing on comfort, potentially removing some of the life-sustaining interventions, not performing CPR. And the son exercising understanding might say, I understand and agree. Sometimes clinicians worry that that recommendation piece is unilateral. It is certainly part of consent and a necessary part of shared decision-making. What makes it not unilateral is that the clinician is recommending in relation to the patient's expressed goals and values. Or we may end up in a different situation that anyone who has worked in an ICU has ended up in, where Mr. J's son says, Mr. J has told me his whole life that what's most important to him is being alive no matter what. He told me a week ago that he wants any medical intervention possible to be alive. And if his heart stops, he absolutely wants you to try and revive him. Now, the clinician in that situation may make a unilateral decision and say something like, we're going to do what we can, but CPR in his condition will not be effective, and we will not provide this. This is not a recommendation couched in his goals and values. This is a unilateral decision of the healthcare team. Now, Mr. J's son may say, okay, I understand, meaning he's not opposing that, he assents to that. Assent is more ethically fraught, certainly, and there are power dynamics at play in a clinician and a patient or decision maker relationship. Does the decision maker even know that they can oppose? But there's a robust ethics literature that supports assent as potentially ethically appropriate, that in some situations, like around life-sustaining interventions, there may be situations where an ICU team can make a unilateral decision, and if there's not active opposition, then that's acceptable. But what if that doesn't happen? What if Mr. J's son, the ICU clinician says, we will not do this, and Mr. J's son says, I disagree completely. This is not what he demanded. He always said, revive me, and I request or I demand that you revive me. Now we have a situation of conflict. So what do we do? So before I move forward with talking about futility, which is where I'm ultimately headed, I want to address what should be coming to mind when we are in these episodes of conflict and frame what we're talking about. So the first thing is we need to mitigate conflict and deal with it with communication when it's coming up. So yes, we absolutely must do better at advanced care planning, and we must do better at communicating and supporting and building trust with seriously ill patients and their families. The annoying part of calling an ethics consult is 99% of the time, the answer is going to be talk more with the patient, right? So yes, I absolutely accept this. I also recognize that these are not things that we are doing well as a system, and we've been trying and still fail in many ways. And I mean, system as a healthcare in the US generally. And we've been trying and failing in many ways to improve this for 30 years, but this is absolutely the crux of how we need to deal with conflict. Yet, even in the situations where we can do the best communication, the best advanced care planning, there are always going to be fundamental differences in values, and therefore we are always going to have conflict that we have to deal with. You know, Mr. J might have had the best advanced care planning and really high-level communication with his son, and his son may reiterate that his values are to maximize medical technology no matter what. So we always are going to have to deal with conflict. The other part that often comes up in these discussions is resource utilization. And I fully agree that as a society, we need to address resource utilization at the end of life. It represents a not insignificant portion of healthcare spending, and there's a lot of discussion to have around that. But in general, when we're talking about routine clinical decisions in conflict at the bedside, we are not talking about resource allocation frameworks for making decisions or resolving conflicts. This is a very different situation from zero-sum resources like organ transplantation, where there are protocols around this. Or, and I want to make clear because we're talking about life support, it was not that long ago that we were developing SOFA score protocols and other things to figure out how we allocate life-sustaining resources. That isn't a public health or a crisis standard, and is not in general how we are making decisions about resolving conflicts for life-sustaining treatment at the bedside in this routine clinical care. There's no clear framework by which an individual clinician would take it upon themselves in this routine care to say, I'm going to resolve this conflict by deciding myself how resources are going to be allocated. So that's not the frame we're talking about. So what do we do with conflict? Or a fancier ethics way of saying this are, what are the bounds of patient autonomy? What are our obligations around patient requests for life-sustaining care? And a lot of the ethics around this centers around, and again, everything I'm saying is argued and can be argued multiple ways, but a lot of the ethics around this and the formation of clinical autonomy in clinical ethics distinguishes refusals and requests. So just dipping the toe in philosophy very superficially, the view of clinical autonomy is often formulated around an idea of liberty rights and puts more weight on the patient's ability to protect themselves from things happening to them, but does not necessarily mean that they can demand anything that they want within medicine. And we put heavier weight on patient refusal versus a request. So in practice, this generally means that patients with capacity or their surrogates with some limitations can refuse any intervention. We know this, it's again codified in Supreme Court cases and legislature and very common in clinical ethics. A patient themselves can and does every day say, I want to focus on comfort, I refuse a ventilator. Patient requests can be more limited, and they can be denied in some situations. That certainly includes if the request is for something illegal. There are other situations. But there's also a clinical ethics framework in which a patient request may be denied if the care is considered futile. So now we've arrived back at this idea of futility in clinical medicine. So futility as a concept is ancient. This is a piece of a painting of the Danaids, which is the 49 sisters who all murdered their husbands the same night in Greek mythology and were sentenced by the gods to spend eternity trying to fill a basin that had a hole in it. Also Sisyphus trying to roll the boulder where it rolls back down. So futility is an ancient concept that we all know intuitively. It's something that cannot be achieved, an impossible task. But in clinical medicine, it's actually a much more recent description and phenomenon. So as I mentioned, starting in the mid-1900s, there was a recognition and a support for the eminence of autonomy, often in relation to other ethical principles. This corresponded at the same time with drastically changing technology in medicine. much more widespread use of intensive care units, ventilators, much more widespread use of CPR. And what that ended up coming together in was physician concern over where they should bound using these technologies in light of patient requests. So the first description of futility in the ethics literature or the clinical literature in general was in 1987. So this ancient concept, again, a much more recent phenomenon in thought of clinical ethics. So it came around in the 1980s. And then in the year 2000, a group of bioethicists from Chicago, names Dr. Weiss probably recognizes, published this paper in the New England Journal where they recognized that there had been an explosion of discussion in the ethics literature with hundreds and hundreds of articles written in the 80s and 90s, trying to come up with this bound that I talked about at the very beginning, trying to define futility, meaning come up with a definition of what are the criteria by which we may withhold something or withdraw over the objections of a decision maker. And so in the year 2000, and you can tell by the title of their article, they summarized the lack of consensus around reaching this definition and thereby the failure of some sort of blanket definition or idea of futility. But 25 years later, many of the ideas of futility that had been described in the 80s and 90s, despite their flaws, persist. And I'm getting called on ethics consults where people are conceptualizing futility in some of these ways, where we know qualitatively that these are still common uses of the term futility in clinical practice. And so I want to go through some of those and talk about their flaws and then talk about where we move forward. So the first one of the conceptualizations of futility is that we could identify futility quantitatively. And this was a well-meaning effort to move away from varied clinician judgment and try to set empirical bounds and then define futility around that. So what if we could predict the probability of success of an intervention and then say below some probability, below some threshold, we would call that intervention futile, probability of success. So the most influential formulation of this was by Schneiderman and colleagues first in 1990, where Schneiderman wrote that when physicians conclude, either through personal experiences shared with colleagues, or consideration of reported empiric data that in the last 100 cases, a medical treatment has been useless, they should regard that treatment as futile. And so Schneiderman picked that we can observe 100 cases and it hasn't worked once in 100 cases, trying to form a 95% bound or confidence that the likelihood of success is no higher with 95% confidence than a threshold of 3%. You know, less than 0 out of 100, we can say that with 95% confidence, you know, at most 3 out of 100 could possibly be successful. So he set a threshold of 3% or 1%, depending on how you think through what he was arguing. But why that threshold? So that is not a clinical decision, that's a values-based decision. And there was a bunch of qualitative work in the 90s that tried to reach consensus among physicians around what threshold we should set. And there was wide variation in what physicians thought, with arguments that, you know, any threshold above 0 should not be considered futile. And then as far as this was reported in the literature that physicians were arguing that anything with less than a 60% chance of success may be considered futile. So obviously wide variation among physicians. And we know even wider variation among patients, right? You know, any of us have interacted with a patient who says, if it's a 1 in a million chance, I want it. And so what is the right threshold? There was this effort to come up with this and it failed. You know, we as a society, as a group of clinicians, as an American healthcare system, have not set some quantitative threshold by which we bound interventions and withhold them automatically below that threshold of success. Now, let's say we could do that. We certainly haven't, but let's imagine that we could. We still have other problems with quantitative futility. One is, how do we come up with, you know, how do we prognosticate whether we're going to be below that threshold? So I could put a bunch of references on this page. I didn't, but we know that clinician judgment can be very inaccurate around prognostication, sometimes less accurate than a coin flip. So this move to try for quantitative futility corresponded to a bunch of epidemiological studies and ICU scoring systems like the Apache and other systems, where they tried to put together this quantitative futility with attempts to better quantify or prognosticate using data sets and epidemiological means, what prognoses were for different interventions or for ICU survival and those kinds of things. But you do different studies and you get different prognostic scores or different evidence. And so what study do you choose? So even if we could set a threshold, we'd be facing these problems. And even more deeply than that, and again, dipping my toe in philosophy and statistics, we need to recognize that arguably it is actually impossible to do what we're trying to do for this individual at the bedside, to set quantitative futility. There's a statistical and philosophical argument called the reference class problem that recognizes that when you're making a prediction for an individual, you're making that probability prediction in reference to some other class. And each individual has within them indefinite characteristics. What makes them up is, Mr. J has pancreatic cancer, he's in the ICU, but he has indefinite numbers of things that you could choose to compare his individual self against a class. So you could compare him against, the likelihood of survival of pancreatic cancer patients or the likelihood of survival of ICU patients with these measurements. But there's an indefinite number of references that we could predict that probability against, and therefore we could choose an indefinite number of probabilities. So even if we set a threshold, if we're going to say that we're going to override this person's autonomy, we cannot be definitive that this is the actual probability of what's happening and then use that as a probability to withhold or withdraw. So quantitative futility is problematic. There's an interesting sort of resurgence of interest in quantitative futility around AI. So AI is going to be much, much better at prediction in all of the things that we're doing. It's going to be able to take in many more of these characteristics. It's going to give much narrower confidence intervals and better statistics around predicting mortality, success of an intervention. But it is not going to solve the threshold problem. It's not going to tell us as a society and help us, and go beyond us reaching an agreement on what the threshold should be. And it does not solve the reference class problem, even though it can take in so many characteristics. Arguably, there's an indefinite number of characteristics we could assign a probability in relation to. So this idea of quantitative futility seems fundamentally flawed. At the same time, the discussions of quantitative futility were going on, there was discussions of qualitative futility. It could something be defined as futile if it wasn't going to be able to achieve some goal. And so this was the idea of, and this is what I hear in clinical practice a lot. The resident is exclaiming, this is futile. Futile to what end? Futile because I don't think they're going to be able to get out of the ICU. Schneiderman in the same paper argued another pervasive conceptualization of this qualitative futility and argued that we should define treatments that were as futile and therefore, able to withhold or withdraw over objections if they merely preserved permanent unconsciousness or failed to end a patient's total dependence on intensive medical care. So that's setting a qualitative end, but who decides that? Again, it's a fundamental values-based decision that was hotly argued in the literature for 20 years and never reached any sort of consensus. Schneiderman felt that goals that, interventions that only were able to achieve these outcomes were not worth it or futile. Patients don't feel that way. You've had these discussions. Who decides whose values are being honored in these types of settings of bars? And then who sets the bar and it can move? Like I said, I'm called on consults. I'm worried, Mr. Ethicist, that these are futile because the patient will never be able to wake up. What we're doing is futile because he'll never get out of the ICU or he'll never survive to discharge to the hospital or never be able to walk again. Those are values that you may be distressed that we cannot achieve. But to say at a blanket definition of futility that we're going to set these as values as a group of physicians, overriding the values of the patient, there's no consensus around that. And I don't think a mechanism to reach consensus around that. And so this idea of qualitative futility is also flawed. And I'd also say that many of these judgments of qualitative futility or some bar that we should set are heavily prone to our own implicit and explicit biases. So qualitative futility is based on values, which can be biased. But then let's also not forget that if we're setting a qualitative end, we need to prognosticate that end. We need to predict a probability that they're not going to achieve this thing that we're setting a bar at qualitatively. And I just spent some time telling you about we can't do it quantitatively. So this idea of qualitative futility as some sort of blanket definition that we can achieve is also fundamentally flawed. So you guys are like, okay, is anything futile? So again, controversy around all of this. I'll put up the warnings. But I subscribe to what many ethicists have argued in the literature is using a very narrow definition of the term futility. And this has been referenced as physiologic or strict or absolute futility. And this is when an intervention has 0% chance through no physiologic mechanism of achieving an intended intervention. Not 0 out of 100, not 1 in 100, not 1 in a million, 0% chance. In one of the early formulations of this, the ethicist gave the example of a patient with a STEMI with a blocked coronary artery who for some reason is requesting antifungal therapy to unblock that coronary artery. Now, someone can come and argue with me about anti-inflammatory effects and cascades and things like that, but arguably there's no clear physiologic mechanism by which giving an antifungal agent would unblock that coronary artery and achieve the intervention of resolving the STEMI. And so that request could be considered futile in a narrow definition. The problem is most of what we're dealing with in this conflict does not meet that narrow definition of futility, especially for life-sustaining care or things like CPR. This conceptualization of futility, if we apply it to CPR, well, when is there truly, absolutely 0% chance of return of spontaneous circulation? If the patient's decapitated or has rigor mortis, or maybe some like complete outlet obstruction of their cardiovascular system. But these are not the cases I'm being called about in ethics. These are not the conflicts we're dealing with. The pathologists are not calling me that the family is demanding CPR. And so while we have a narrow definition of futility, and I argue that we should hold that, because of the problems of actually defining futility, we should save that word for these true cases of physiologic futility. But that's not what we're dealing with in the conflict around Mr. J, and how do we move through that? The things that we're doing or that Mr. J's son are asking for are not physiologically futile in the conceptualization I've laid out. So now you're asking me, okay, is it ever appropriate to override the objections of a patient or a surrogate decision maker beyond strict physiologic futility? And the answer is yes. So I've spent a long time talking about how we've elevated patient autonomy, but that is not the only ethics principle. And so in these conflicting situations, you have on the one side our interest in honoring the patient's values and respecting their autonomy, but there are competing ethics considerations. I list only a few of them. What about those other principles I just said? Often we are struggling because we feel that what we're doing with these life-sustaining interventions are not beneficial, though that again is hard and can often be qualitatively defined. But certainly we're worried about non-maleficence. That I think is the center of a lot of our distress. We feel like we're doing harm. We feel like we're causing suffering. Where does that weigh in? The patient or their surrogate is also not the only actor in these conflicts. We've talked a lot about patient autonomy, but where is our autonomy as physicians? Where are we as moral agents in the balance of this conflict? And then there's a robust set of arguments around the idea of physicians being part of or having within society a professional or social contract, and that society through our training and licensing has elevated us to take greater control of these interventions and make these decisions, which is a competing ethical argument against patient autonomy. And then there are justice and fairness and resource allocation arguments that I think are valid, but again, I say need to be dealt with more at a society level than in individual conflict decisions outside of crisis standards. You're like, okay, you keep talking. What do we actually do? What do I do about this? And so where the bioethics literature and clinical ethics literature over the last 40 years has coalesced is that we can philosophically argue, and people will still, about a definition of blanket futility. But the reality is we're going to end up in conflict situations, and it's really going to be always a competition outside of strict physiologic futility between competing ethical principles. So the reality is trying to find a process by which we weigh these ethics principles and mitigate these problems. And that's, the best we can do with these situations. And so this view coalesced and was represented in a joint critical care society statement by essentially all of the American critical care physician and nursing societies and some of the European societies, where in 2015, they released a policy statement about responding to requests for potentially inappropriate treatments in intensive care units. And so they defined, and like I've been talking about, potentially inappropriate treatments as treatments that have at least some chance of accomplishing the effects sought by the patient, but clinicians believe that competing ethical considerations justify not providing them. They gave examples in that policy statement that I put here to be illustrative. We can argue them, I'm happy to argue them, and they are not meant to be the encompassing of all the examples of potentially inappropriate treatment, but to lay the framework for what we're talking about. They pondered, intubation in end-stage dementia, dialysis in a persistent vegetative state, CPR in critically ill patients with poor prognosis malignancy like Mr. J. These are not physiologically futile things. We can probably oxygenate the person with end-stage dementia. We can probably improve the metabolic state with dialysis of a patient in a persistent vegetative state. The return of spontaneous circulation chance of CPR being successful in a patient with even very advanced malignancy is not zero. It may be very low, but it's not zero. And so what do we do with these competing ethical principles? And so the policy statement recommended sort of two paths. The first would be an emergent decision-making path in which they left deference to clinician judgment, but tried to put in processes and safeguards wherein in an emergency, they recommend that a physician, weigh these ethical principles and make a decision, often trying to get a second opinion from another physician in an emergency, and make a decision, trying to weigh the principles I've laid out. And if they feel that the weight is such that they should withhold or withdraw, then they withhold or withdraw. But then there's processes to go back and review their decisions. Those are for very emergent decisions. Do we need to do something in the next 10 minutes? For non-emergent decisions, feeling like it's futile to continue critical care for Mr. J, who's stable, who's not decompensating, but relies on critical care interventions, they recommend a 7-step process that begins, again, very much recognizing the need to try to resolve these conflicts with really good communication, pulling in experts in communication, then notifying in writing that the patient or their decision maker that we're entering a conflict resolution process because the clinical unilateral judgment is that we should withhold or withdraw an intervention. Getting a second physician evaluation. And then interestingly, and a big part of this was the policy statement recommended taking these decisions and bringing them to an interdisciplinary institutional committee for review, like an ethics committee or setting up a committee for this. Excuse me. If the interdisciplinary committee agrees with the unilateral decision to withhold or withdraw, then the patient, the decision maker, should be offered transfer, should be offered appeal, even up to a judicial appeal, excuse me. And then if all of that goes through, at that point, you can withhold or withdraw an intervention over the objections of a decision maker. So all of the critical care societies essentially got together and said, this is what we think should be the process approach to working through these conflicts around life-sustaining therapy. This was done in 2015. I and colleagues wondered, so we have this overarching professional society document, what's actually happening at the hospital level? So we first tried to get policies from hospitals, and that proved very difficult. Most of this is not publicly available. The hospitals do not make publicly available their processes for resolving these disputes, which is its own ethical problem, I would argue. But we ended up developing a structured survey wherein respondents who knew their hospital policies without giving us the policy could essentially tell us what components were or were not in their policy in an anonymized way. And we sent this out on ethics listserv and got responses from ethicists, palliative care doctors, critical care physicians. And we got responses from 93 hospitals, well, more than 93 health systems, probably more hospitals. And geographically, we captured at least one hospital from all 50 states and Puerto Rico. What we found was 100% of these policies addressed if a patient requests to withhold or withdraw life-sustaining therapy. But a smaller number, 64%, addressed what do we do in areas where there is conflict or the physicians wish to pursue a unilateral decision. And we found very wide variability in these processes and policies. Looking at the 7 steps that were laid out by the professional society policy statement, the majority of hospital policies, of the ones that even address this, the only 2 components were present in the majority of hospital policies: the recommendation to seek expert assistance in dispute resolution and the recommendation to offer transfer if there's discussion of a unilateral decision. Less than half of the policies we found had other components from the Critical Care Society policy statement. So we are currently engaged in a number of qualitative studies and efforts to understand this more. And what we are gathering and is under review in a manuscript is that the reasons are varied for why hospital policies do not seem to align with all of the components of the professional society guidelines. It's not that these policies are older than the 2015 guidelines. The vast majority of them had been updated in the last couple years. What it is one, a fear of litigation and institutional policies being crafted with the help of institutional risk managers and legal departments who often have concerns or barriers around some of these steps. It's also, we found in qualitative work, despite this policy statement, a lot of question and argument over where the locus of this decision-making should be. You know, is it at the level of the attending physician, or how involved and to what extent should the decision-making rely on what's recommended here, a separate interdisciplinary body? These are questions that have not been solved despite the policy statement from the Critical Care Society. So we see a wide variability in policies across hospitals and how we handle these disputes over life-sustaining therapy. But what's actually happening in practice? We know very little. What we know comes essentially all from qualitative work. And one of the most useful studies was done by a colleague at the University of San Francisco, Liz Ng, who's a hospital doctor and a sociology PhD. And she did a very large number of qualitative interviews to understand what's happening in practice. How much is this happening? How are these decisions being made? How do we handle requests for potentially inappropriate life-sustaining therapies? And she too did these interviews at 3 hospitals and found wide variability among providers' individual responses to these situations and their comfort dealing with these situations. And so qualitatively, we hear that some providers will pursue unilateral decisions. Some feel that they'll never pursue unilateral decisions. So variability at the provider level. And then variability across institutions, which we saw at the policy level, but we're also seeing as true in practice and qualitative work. And Liz conceptualized that these types of decisions are under many levels of influence that can, lead to different decisions. And that includes the institutional policy, but even more than that, the institutional culture. What she found and what we found in our qualitative work is oftentimes the clinicians actually think that the policy says something different than it actually says. And there's this sort of culture of here's how we handle these situations. Here's how we deal with unilateral that may not even align with the policy. This is also happening in the background of state statutes, which are variable across every state, and then regional or state cultures and how we approach this, and even national, less so statute at the national level, but certainly culture. And how we handle this as a nation is very different than, if you've practiced in a different nation or aware of how unilateral decisions are made outside of the United States. So all of these varying levels of culture coming down to an individual clinician who's then making variable decisions about how to handle these situations. That's great qualitatively, but show me data. What's actually happening? I don't know. The problem with this is it is incredibly difficult. It's essentially impossible to study unilateral decisions in large healthcare data sets. You're not going to get at this in a billing data set. Even in chart review, it can be very difficult to know exactly where on the spectrum between consent, assent, and conflict a decision was made. The note says a patient became DNR. Was that unilateral? Did the patient consent? We need to do better at our documentation, but even with clear documentation, it can be hard to track this stuff. Most of what we know comes particularly from DNR, and there have been studies where they've tracked unilateral DNR, but we've been talking about unilateral or futile care for 40 years. And in that time, we have less than 200 cases reported in the literature, and all at single or a couple academic centers. So very limited data, very limited ability to actually say empirically what's happening. And that's just for CPR. To what extent are we unilaterally withholding dialysis, ventilators? We don't know. And one of my great concerns is that we see or think qualitatively that there is wide variability in practice and response, even among individual clinicians in the same institution, but certainly across or between institutions. And when you have variability, I think disparities can arise. And so this figure keeps me up at night. This is from a study colleagues did in Chicago. So at the beginning of the COVID-19 pandemic, all of the academic hospitals in Chicago were in a joint bioethics consortium and tried to write policies. One of the policies that came out of that was a policy that codified a process or procedure of instituting a unilateral DNR based on clinician judgment that the patient is failing maximal critical care, which was not defined beyond that. This was separate from other things going on like resource allocation and things like that. It arose more from a lot of discussion, especially in the early pandemic, around fears to providers or who are doing CPR and at risk, and ideas around when should we unilaterally withhold CPR. And the policies came out to say, not just for patients with COVID, but for any patient, in your clinical judgment, if you feel the patient has failed maximal critical care, it may be appropriate to withhold CPR unilaterally. So 2 of the hospitals created an actual unilateral DNR order to put in place if this situation is happening. And that allowed retrospective study. So colleagues studied this at 2 Chicago hospitals between April 2020 and 2021, and they looked at patients who had a unilateral DNR. The inclusion criteria were any patient admitted to the ICU and on vasoactive medications, trying to capture those patients who would be at risk for this sort of idea of clinician judgment of failing maximal critical care. And it compared patients with a unilateral DNR to those who didn't have a unilateral DNR. And then in adjusted analyses, it examined for it adjusted for demographics, for intubation status, and for COVID-19 status. So certainly there are methodological limitations that we can talk about, absolutely, 100%. Is this fully adjusted in the appropriate ways to compare these patient populations? Obviously, the patients who are getting unilateral DNR are going to look different. I agree absolutely with that limitation. At the same time, in these adjusted analyses, we see that there are differences for age, and then for race and language. So again, a limited ability to adjust, particularly for clinical complexity, but still, we saw that Black patients were 2.5 times, had an odds ratio of 2.5 times more likely to receive a unilateral DNR than a reference white patient. And for patients who were primary Spanish speaking, they were 4.4 times more likely in adjusted odds to receive a unilateral DNR than English. This is not definitive. I've said 5 times the methodological limitations, but there's enough here to be worried in my mind. And it is illustrative of what we worry about, especially if we are using clinician judgment for unilateral decisions. All right, so I keep talking, what do we do? You want to know. Again, I said I'm not going to give you definitive solutions, but I would argue that we can't give up on advanced care planning and communication. There's a whole palliative care debate raging in the literature about the efficacy of 30 years of investment in quality improvement and research efforts around this. We still have to keep going. I also trepidatiously say that we need to advocate for societal and legislative guidance around this. Clinicians are left with these intractable decisions at the bedside, and we as a society need to grapple particularly with the resource component part of this. I don't think physicians can triage the types of resources, but I also recognize that the use of intensive resources for 1-2 days of life is a debatable good, but that debate needs to happen at the societal level. And then we as institutions can be more vigilant about this. We should have interdisciplinary and diverse voices writing the policies and developing the processes for how this happens at an institution. We need to do better with data collection so we can actually understand what's going on and then monitor that data for variability and disparities. But many of you are dealing with this today. The residents are going to go back to the ICU and probably have a conflict or a case where they're distressed. So what do you do as an individual? So, keep my job and hire more colleagues. So there's a lot of data that the involvement of palliative care and my wonderful colleagues I see and ethicists can really help with these situations at the bedside. Don't give up on your own communication skills. This is lifelong practice. I, as a palliative care doctor and ethicist, am still going to skill up and treat as a procedure my communication practice, and we all need to, because that's the best way to resolve these conflicts. But also take care of yourself when you're going through this. There's strong data that these types of situations directly contribute to provider-level moral distress, but also is a very high risk factor for burnout, and even mental health issues and diagnoses. So take care of yourself. There are a lot of resources available. Rely on your colleagues. And, we'll all get through this conflict by conflict. I want to acknowledge a lot of my research colleagues and mentors. I also want to take a minute to acknowledge Ken Goodman, who's here and who has really helped me think through and process a lot of this from a research standpoint. Ken, if you haven't heard, thinks that we're not going to let him. He thinks he's going to retire this summer after running the Bioethics Institute and helping so many people in this audience and so many patients and their families deal with these very difficult ethical issues and conflicts. And we can't thank him enough. All right, so I will open it up to discussion and debate.
Dr. Huber, thank you for that eloquent and real, the words just flowed eloquently from your mouth. I'm just trying to understand the concepts, and you just made them so easy. I have a couple questions maybe to start off with. First is, you talked about a dyad, the caregiver and the patient, including patient's family. Where does clergy fit in that picture? Because oftentimes there's a little bit more black and white contrast there than you'll find if individuals on either of that side of the dyad, if I'm making myself clear.
Yeah, I think that's a very important point, and I wanted to leave time for discussion, so there's so much more we could talk about, and I appreciate the opportunity to talk about that. I presented this for simplicity as a dyad, but there's often many family members and then many other people, that are involved in these types of conflicts and decisions. And also implicit in your question, I talked broadly about values, but values come from many different places. And that very much includes faith-based values or practices. And as many of you have dealt with and know, that can be a huge part of the decision-making and the values that can then lead to conflict and play into these unilateral decisions. So to answer your question, the involvement of chaplaincy is incredibly important and helpful. And then particularly the involvement of the patient's own spiritual leaders and clergy, because where that can be very helpful is helping the patients, their families, their decision makers place their understanding of their faith tradition and values in the decision. And sometimes what they feel is a faith-based decision that leads to this conflict, actually in discussion with their clergy, there is space in the faith for allowing, a decision they may make that may resolve the conflict. Sometimes not. Sometimes the faith-based tradition, the clergy leaders are stating that the values are to maintain, life support or something in opposition to a healthcare team trying to do a unilateral decision. But that's helpful too. That is cementing the values that we're dealing with.
Excellent. And one last quick question. Do we have at the University of Miami a interdisciplinary committee that you note to review these cases?
So these cases are always able to have the involvement of ethics, which is, in our institution, a consultant-based ethical analysis that often comes to the committee, which is interdisciplinary. We have an interdisciplinary committee that can review these committees. By policy, it is not mandated that an interdisciplinary committee reviews this. And that goes back to, and that's something I've worked on from a quality improvement perspective at our own institution, comes back to very real questions about litigation liability and also where the locus of decision-making is. And if we had an interdisciplinary body who made a decision and then the attending physician was in opposition to that decision, that's the attending of record. These are the types of debates that are ongoing and solved or thought about in different ways at different institutions. And I don't think was well or sort of thought out or articulated to give a controversial opinion in the 2015 policy statement.
Thank you, Dr. Punjabi.
Great talk. By the way, I'm a student of Siegler. A few of you know that name 30 years ago, though. A couple of points. You showed a graph of how Hispanics or Spanish speaking, older, et cetera, et cetera. A couple of things I want to make about that slide. First and foremost, very large confidence intervals. And it's
Absolutely.
in a log scale. So we have to be very careful about case mix, et cetera. And you qualified that. Let me now take you to the probability problem that you gave. I found that discussion very interesting, that you and others have struggled with a probabilistic definition of where to draw the line. Let me pose a question to you. The Supreme Court or any legal court uses, when you're looking at a criminal case, they'll say, well, without doubt. So that draws the probability at 0 or close to 0. But when you think about medical legal cases, they'll say more likely than not, right? So that's a probability at 50%. I wanted to ask you this question. Why don't we use a simplistic definition of probability in our own thinking? And I think we do, by the way, in the sense that more likely than not. It's simplistic, it makes sense. So we're not caught in this draw a line, have some thresholds. Where did you get those thresholds? I think it's a more likely than not question. What do you think of that? Dr. Goodman, what do you think of that? And aren't we doing that intrinsically?
Yeah, I think that's a really important point. And the reference class problem that I mentioned that you're talking about is actually one that is debated in the legal literature as well. You're talking about cases, and they sort of decided that at a societal or a legal level in ways that we have not at the medical level. And I think you make a very good point. I think that the argument against that is drawing the firmest possible line against violating patient autonomy. And the arguments I made against using these quantitative judgments, what we looked for, what the ethics looks for, and as a society we can debate whether we need this, is a sort of absolute probability. And what you're describing, I think, is certainly a conceptualization that could be used, but is different than an absolute probability.
Dr. Deshpande.
Thank you for that, and for following Dr. Goodman's footsteps of making sure we ended a session with more questions and answers. A quick question on absolute futility. And so as in GI, where PEG, I think, is probably one of these big ones. And when you say absolute futility, even that has some nuance, because the absolute likelihood of putting in a PEG and making that person less advanced demented again is 0, but their prealbumin can go up. So what is the absolutism? I would love to use that other example more often with PEGs, in which I feel non-maleficently unclean about doing. So I was wondering that. And then very quickly, are there any societies that you feel have done, which is a very US-based kind of talk, that have done a good job making their society largely kind of happy with how they approach this?
Yeah, so to your first point, and thank you for the opportunity to sort of clarify the physiologic futility. It's physiologic futility defined to an end. And in this conflict, it is the end sought by the decision maker. And so if the decision maker is seeking the provision of nutrition, separate from what, again, is qualitative goals around survival and those kinds of things. And this is where communication and all of that is so important, because you need to clearly understand the goal. But if the decision maker is asking for the albumin to get better, or they're not going to articulate exactly that way, but they say, I want them to be alive. If they, I need them to get protein in their body, the placement of the PEG is not physiologically futile. It can achieve that goal. It can achieve another qualitative goal. And then you're left with, exactly like you're saying, the competing ethical considerations, the maleficence and so forth. But the physiologic futility is can the intervention physiologically achieve a goal sought by the decision maker? And if the goal is put some food in the stomach, physiologically, the PEG is going to do that.
Dr. Goodman wanted to comment, and then Dr. Goldman.
One, that was an absolutely elegant talk, and in a way that our colleagues here might not know. One of the things that Dr. Huber has done in a comparatively short time is he is co-leading the ethics process for UHealth. He's working with a number of colleagues from around the entire medical campus to work on these policies and other issues. You see his work that he referenced modestly in what we'll call medical epistemology has actually ended up being really quite useful to colleagues around the country. That's just an emo point. Wonderful talk, but more significantly perhaps is that we're having these conversations, and that under wise leadership and with supportive colleagues, interesting and important things are happening in ethics at our Miller School of Medicine. Nice talk, Mike.
Thank you, Dr. Goodman.
Great talk. So this is, the third state I've practiced medicine in, and every state has been quite different. I know when I came here, I was in the ICU, I'd see the attendings say, Florida statute, whatever, we can, unilaterally make this decision. What sort of efforts are there here and sort of more broadly when residents come, when new faculty come on board to actually make them aware of the logistics? Because I know I came here and I had no idea what those statutes were in Florida compared to Pennsylvania. What efforts are there with new faculty orientation or things like that?
Good question. There probably need to be more. I didn't show this because it's very preliminary, but the same group of colleagues I work with, we are presenting at ATS this year, a sort of legal epidemiology of state statutes, which are highly varied. To more specifically answer your question, I think we could do a better job. I think it happens at the program level, like residencies. I give a lot of talks. I talk about this when I give the talks to the programs, but we're not getting to all of them. So I think it's probably highly variable. I think it's a good point and gets to the idea of even more than policy, culture starts to play into this. And so, we'll ask the residents, how do we handle this? And I'll get different answers from different residents who say like, oh, well, my attendings do this, or, we do other things differently.
I want to thank everybody for participating in Grand Rounds today. Dr. Huber, excellent job. I remind everybody to check the chat and the QR code as you exit for the link for CMO and CME. And I look forward to seeing everybody next week. Have a great and wonderful day.